moderating the session. Okay. Yeah. If you can able to introduce Dr. Uday Kumar.
Yeah. I think let him go.
Mohan?
Yeah, I can hear, sir.
Are we live?
Yes, we are live. Good afternoon and good evening, everyone. We welcome you all to Karnataka Orthopedic Association webinar on proximal tibia. I am handing over the proceedings to the moderators. Over to you.
Yeah.
Dr. Mallikarjun Swamy is here, the president of Karnataka Orthopedic Association. He has just joined in. Dr. Jagdish, how do you want to proceed?
Hello, sir. Dr. Mallikarjun Swamy, sir.
He's still connecting to audio.
Dr. Mallikarjun, sir. Hello.
Yeah, it is, I think, taking time.
We will start. We will start.
We will start, and in the second, between one or two presentations, he can talk.
Yes.
Hello. Yeah.
I think he's here.
Yeah. Dr. Mallikarjun Swamy, can you put on your video?
Yeah, we'll do that.
Yeah,
yes, sir.
We can see him. Yeah.
Yes, sir.
Can you give a welcome address to all of us, please?
Yeah. So, good afternoon, everybody. I'm most happy that your most highlighted group has joined for the KOA webinar today. I'm really happy, and especially Dr. Uday Kumar and Brahmaraj and Ram Prasad, Jagdish, Bhushan, and Prasad. So many other galaxy of eminent speakers are there. Most welcome to you all. Without wasting time, I think you should start the programs. It will be useful for everyone, including me. Thank you, sir. Thank you, Nanda.
Sir, thank you so very much.
Yeah.
Yes, please.
So without.
Yeah, we can start the first talk, please.
Can I start?
Yes, Dr. Uday Kumar, please start.
Yeah. Anyway, thank you. I thank the Karnataka Orthopedic Association for giving me this opportunity to present this talk. I also thank Dr. Jagdish to organize this program, and of course, talk to Dr. Neeraj, who's always there for us. Now, how do I plan and approach a proximal tibial fracture, which is a common injury? Proximal tibial fractures are about 1 to 2% of all fractures. If you see, the lateral plateau is involved more, about 55 to 70%, and the medial plateau around 20 to 30%. Bicondylar is around 10 to 30%.
Sir, please adjust your speaker, sir.
Can you hear me now?
Yeah, it is weak. That's all. Yeah.
Okay. It has a bimodal distribution.
Now it is better. Yeah.
Better, no? Very common in young adults due to road traffic accidents, high energy injuries, common in males more than females. Very common also in the elderly, low energy injuries because of osteoporotic bone, and females are more common than males. The functional impairment of these injuries, it produces joint malalignment, instability, and post-traumatic arthritis, which my other speakers will speak about. When you take a history of a patient with this type of injury, check whether it is of high or low velocity, check the patient factors, the age, bone quality, any comorbidities, and what are the functional demands of this patient. Do a general physical examination as per the ATLS scores, the airway, breathing, circulation, check for other injuries, and then go to the examination of the limb. Check whether it is a closed or an open fracture. See whether there are blisters, any compartment syndrome, and see whether check the soft tissue integrity. Most important, do not forget the neural status, as the common peroneal nerve is very commonly injured. Check for a vascular deficit, as the popliteal artery is just behind there, and document these findings. Next, take X-rays, our routine X-rays, AP and lateral X-ray of the knee, including the whole tibia, and go for a CT scan. Now, this CT scan helps in surgical planning. It helps us to assess what is the depression of the fragments. Is there any comminution? And what is the plane of the fracture? Please ask for a 3D recon, which always help us to plan the surgical approach. And what is the position of the patient on the operation table? Now, once you have done this, you make a classification of what type of fracture it is. We all know the AO classification: extra-articular, partial articular, and complete articular. But we still follow the famous Joseph Schatzker's classification today, the 6 types, type 1 to type 6, and we'll go to each of them later on. Now, Joseph Schatzker, along with Mauricio, they used a CT-based classification into columns, anterior and posterior, and each of them are divided into medial and lateral columns so that you can understand the fracture. So this CT-based modification of the Schatzker classification, what does it give us? It gives us the plane of the fracture. It gives us which surgical approaches to take and what should be the position of the patient on the table. Also, an MRI is taken to study the injuries to the soft tissues. 91% of the time lateral meniscus is involved in a lateral condyle fracture and 44% medial meniscus. The ACL, PCL, and other collateral ligaments are also injured, which my next speakers will speak about. So, management, non-operative cases. When do I treat non-operatively? Usually in the elderly who are not ambulatory or minimal ambulation, their fracture has got just less than 5 millimeters of displacement. This patient I treat conservatively with a knee brace and non-weight bearing for 8 to 12 weeks. Now, what are the indications for surgery and how do I plan? The absolute indications for surgery will be a proximal tibial fracture with a vascular injury, with a compartment syndrome, an open fracture, or a floating knee. The other indications are if there is an articular displacement of more than 3 millimeters. In addition, if there is metadiaphyseal translation of more than 1 centimeter, if there's an angular deformity of more than 10 degrees in the coronal or sagittal plane. So the treatment principles do not change. As for all intra-articular fractures, you do an anatomic reduction and rigid fixation of the articular surface, that is absolute stability, and stable fixation of the metaphyseal region, that is relative stability, and start early range of motion as early as possible. Now, important thing is keep the adequate implants and accessories in the OT when you plan for this. Keep all your regular instruments, 4 mm, 6.5 mm, CC screw set. We have different anatomical locking plates right and left today with all sizes. Please keep them in the OT. You may require special plates like the posteromedial plate as the one shown here. Keep distal radius T plates. Some people also use a femoral distractor and keep bone substitutes. So once you keep all of these and anything more, then you are ready for surgery. Now, Schatzker type 1, how do you plan to fix this fracture? This is a split of the lateral condyle as seen here in the X-ray and CT. Now, my plan for this will be an anterolateral approach. The approach will be spoken by my next speaker. Isolate the lateral meniscus, do a submeniscal arthrotomy, and fix with plates and screws. That will be for the type 1. Now, when I go to type 2, this is a split depressed fracture. If you see the X-ray and the CT, how do I plan to fix this? Same, use an anterolateral approach, elevate the depressed fragments in the fashion shown, pack this area with bone graft, and then fix it with plate and screws. So most important is the articular surface. Schatzker type 3. This is a central depression as you see here in the CT and in the X-ray. In this, if you have, if you can do an arthroscopic procedure, then you can use it with the scope, see the depression, make a window in the cortex, elevate the articular cartilage and depressed fragment, bone graft it, and fix it with screws. Otherwise, you have to do a submeniscal arthrotomy. Now, Schatzker type 4. This is a split fracture with a medial plateau which is broken. So this is the CT in this. Be careful of this case because it is associated with many vascular problems. So the plan will be a posteromedial approach, isolate the fracture and use a posteromedial plate and fix it in that position. If the fracture extends medially, then use a medial plate and fix along with lag screws. That is for the type 4. Type 5 and 6. Can you hear me?
Voice is very
Hello?
much.
Dr. Uday Kumar, your voice just went away.
Can you hear me now? Hello?
Yes, yes, we can hear you. Go ahead.
Yeah. Sorry, there was some. Fine. So in type 5 and 6, this is a bicondylar fracture. This is the sixth, this is the fifth one, this is the sixth one. Study the CT, all the fragments which are there. Now, if you see this fracture here, you have a lateral split with a depressed fragment corresponding to this in the CT. You have a posteromedial fragment in the X-ray corresponding to this in the CT. So your plan will be first do a posteromedial approach, reduce the medial plateau, fix it with KOAs, and pass a posteromedial plate or the special plate. Then open anterolaterally, elevate the depression, fix with lag screws or with also a bone graft and a lateral draft plate. So that will be the plan for this, where you will fix both columns and use a dual plating in this system. Now, for example, if the skin tissue condition is bad, say for example, medial surface is like this, the lateral surface is like this, you have blisters and a compartment syndrome. In such situations, it is an emergency condition to do a fasciotomy. I use both a lateral and a medial fasciotomy. Following the fasciotomy, I go and use an external fixator. Now this mnemonic has helped me always. It is called span, scan, plan. Span means span the fracture, scan, do the CT scan, and then plan the fixation. But wait till the soft tissue has healed, wait till the wrinkle sign has come, then go ahead and fix. Now there is an unusual variant called as a posterior shear fracture. These fractures do not fit into any of the classifications. They may be on both sides, medial and lateral, and it usually needs a posterior approach. See, for example, you have a variant like this. This is a posteromedial fracture with a significant joint involvement, a significant displacement. It is unstable. It needs a posteromedial approach. For example, this patient had an RTA, a young man, showing a posteromedial fragment. When you do a CT, it shows you a big piece of fragment here. This is the MRI showing you the piece here. So it's an isolated posteromedial fragment, which requires a posteromedial approach and a fixation in this fashion. My next speaker will describe the approach to you. And this is done in the supine position. Right. Similarly, you have a posterolateral fracture. This is an uncommon fracture. It's usually missed on the X-ray. It is more comminuted than the medial side, and it requires a posterolateral approach. The common approach is the Frosch approach. Now, in this case, you have an isolated depressed fracture here. It is not very clear, can be easily missed in this X-ray. But when you take a CT, you see that there is a gap here in the AP view and here in the posterolateral view. So this requires a posterolateral approach of Frosch, which is without a fibular osteotomy. a direct approach with a buttress plate fixation. You can use a small radius T plate. So in this talk, I have covered what are the common fractures and the unusual variants with their problems. So take home message will be understand the fracture anatomy with the X-ray, with the CT and 3D CT. Respect the soft tissues. Don't be in a hurry to go and operate a fracture with blisters. Plan the surgical approach thoroughly. Keep all the necessary implants and accessories in the theater. And only then you should go ahead. If you fail to plan, definitely you plan to fail. Thank you.
Yeah,
Hello?
thank you, Uday Kumar sir. That was a very nice and brief introduction.
Yeah.
Everything around these fractures has changed in the last 10 years. The planning, the way we investigate it, and the classification. And we'll be taking some questions for discussions so that we can have small discussions in between the lectures.
No trouble.
So first question to you, everybody can take this question, is how relevant is the SAGA classification nowadays?
How relevant it is? Well, only for the basic types it is very relevant. But because of the types of injuries and road traffic accidents we are seeing today, now I showed you the completely posterior type of fracture. We are getting quite a number of them, posteromedial, posterolateral, which don't fit into the SAGA. But for a working classification, definitely it is useful. It gives you a planning to do. If you get uncommon,
nowadays it is an extra, not an extra-based classification, it's a
Yeah.
CT-based classification.
Yeah.
So when are you going to do the CT?
When do I do the CT?
Yeah, after putting the X-fix or before putting the X-fix or
No, always like we follow. It is span,
the mantra.
scan, plan. Span the joint with a trans joint fixator. After the traction is put on with the external fixator, after that I will do the scan.
And
When you are using an external fixator.
Yeah.
If I'm not using an external fixator, I can go ahead and do it with a traction.
Okay.
Because I don't use it in all cases. All cases I don't use an external fixator. Wherever
So mostly you'll be asking for a 3D CT, axial cuts or 2D CT?
For me, all the cuts are important. I ask for the coronal view, I ask for the sagittal view, and I also ask for the 3D CT.
Yeah, it is actually said that the axial cuts at the level of the fibula head is the most important. It makes sense to have one when you are planning.
Correct.
Anyone has a difference of opinion of doing the CT and what point of time? Dr. Ram Prasad?
You see, I'll have to ask him to unmute himself.
Unmute, sir.
Please unmute.
He's not unmuted.
He is not unmuted.
Yeah, Dr. Jagdish sir, you have any difference in opinion when the CT has to be done? Dr.
Dr. Rampasad has to unmute.
Yeah.
He's unmuted. Yes, sir.
Yeah. Can I speak now?
Yes, sir.
Yeah, definitely.
Yeah, I think usually what I feel is that the type 1 and classification of the 3 column is really good, very easy to understand. 3 column is a newer type, very easy to tell and understand, no doubt about it.
Yeah.
But traditionally we are used to this classification of classification. But the type 1 and type 2 and usually type 3, usually the swelling is not much. But what we do, if the swelling is there, we automatically put on a knee spanning fixator. We'll wait for a swelling to settle down for mostly depending on the wrinkling sign for a week or some time. Then we'll plan accordingly for the type 4, type 5 and type 6. So always we'll do the CT scan after the fixator. Whenever you plan for a fixator, because the reduction is almost about 80%, will get reduced, the knee will get relocated. So for us, the CT is mostly after the external fixator.
Yeah, agree.
Someone pointed out the other day that the SAGA classification is nowadays mainly used for triaging the fractures to find out which fractures are more dangerous, and that is done in the ER. Of course, we are doing CT scan for all fractures, and it's a preliminary assessment. But X-rays mostly show the tip of the iceberg. Most of the iceberg.
Very correct.
Yeah, very right.
Yeah.
So this is Dr. Mohan. So Dr. Uday,
Yeah, tell me, Dr.
just a quick question, because for some of the people, I think, we should also mention that the role of a hybrid fixator, especially if there's not much displacement in the fracture, there might be a role for a hybrid fixator, both as a final solution as well as if we have to do a, fasciotomy and things like that. Certain subset of fractures might be amenable for a hybrid fixator, whereas, both the permanent fixation as well as, a bailout procedure.
I agree, Dr. You can use a hybrid fixator. You can use a Elizarov fixator, whichever you are comfortable with. But a hybrid fixator is definitely useful, no doubt.
In which of the cases do you do a CT angio or even a Doppler? Some of the fractures are very dangerous.
Only when there is a vascular injury. If there is a vascular injury, naturally the vascular surgeon is called, and some of the vascular surgeons who, when I have seen, they have used the Doppler and they ask us to put the external fixator quickly and they proceed. Some of them wait for the CT angio. Some of them don't wait for the CT angio. This is my personal experience where we have found these. Well, you can, if there is enough time and if the radiology is ready for the CT angio, you can do it. But majority of the time they do a good duplex Doppler scan. And they find once it is blocked, they say, put your fixator quickly. Then they go ahead and they
any
do
particular
repair.
Where you are more cautious, where you want to do a CT angio without.
Exactly.
Yeah.
You have to be more cautious.
Type 5 or type 6.
Better
or the intercondyle fractures.
Yes. The commonest is in the type 4. It starts from the type 4 Shatska. The big, large medial fragment, it goes and causes tremendous neurovascular problems. Type 4 and then type 5 and type 6.
Do you want to put external fixators in all the cases?
I don't put external fixator in all the cases. I usually put them if they are probably from type 4 onwards, 4, 5, and 6. For type 1 and type 2, or even type 3, if there is a central depression, I don't think there is, unless there are blisters, unless the soft tissue is bad, a lot of abrasions, compound injuries. In such cases, even in type 1, 2, and 3, I'll put a net.
How long would you wait after the external fixator for wrinkle sign? Are you sending the patient home?
No, we don't send the patient home. We keep the patient there because if you have done a fasciotomy and if you have put an external fixator, we will require dressings nearly every day or every second day, and you can be studying that. Maybe it takes about a week's time. Some cases have taken up to even 10 days. It's like a calcaneal fracture. You can't say exactly it will take 3 days or 4 days. It may take a week's time. It may take even 10 days.
And would you tell me your experience regarding the blisters?
Blisters are of two types.
What is your policy?
No, you have two types. One is the serous filled blisters and one is the blood filled blisters. Serous filled blisters can always be, we don't have to open them. You allow them to collapse by themselves and dry up. The blood filled blisters usually indicate that the injury is more severe. Hence, the injury to the muscles and tissues are much more severe. So in blood filled blisters, we have to observe more so that the compartment syndrome and muscle necrosis underneath. Some of them open the blood filled filters, some of them don't. But maybe blood filled blisters into a sterile needle, you can open them and take them.
Do you rupture the blisters? Do you?
We don't rupture the blister. We just use a sterile
put some
needle
kind of ointment or anything like that.
Yeah. Just aspirate and just put some ointment. But
it is
blood
actually
filled blister is more. A blood filled blister indicates a more severe injury.
Yes, of course. Yeah, it is actually said that the static factors are the X-ray, the fractures. The CT, X-ray, and the MRI will be remaining like that only. But the soft tissues will be evolving.
Yes.
Over a period of time, mostly in the first 24 hours. So it is very important to keep a very close observation on the soft tissues. So what is your protocol like? When do you see the when do you come back and see the patient once again?
No, we inform in case suppose we have seen blisters coming in within 8 hours, within 6 hours.
Yes.
So
yes,
it is
of
a
course.
constant watch. The registrar or the
To watch the 5 Ps.
yeah. You have to watch the 5 Ps.
Dr.
Definitely.
Maji, sorry to interrupt. So I think questions finally we can ask the entire panel.
Fine. You can start with the
We'll
next
continue with the talks.
Yeah.
Okay. Okay. Next patient will be by Dr. Brahmraj. He will be talking on the approaches.
Good evening, everyone.
Good evening, yeah.
I'm Dr. Brahmaraj. The topic given to me today is to talk about the approaches on the proximal tibia. At the outset, I would like to thank Karnataka Orthopedic Association, all its office bearers, especially Dr. Jagdish, for me to give this opportunity today to talk about this topic. So at the outset, as we all know, proximal tibia fractures are the common lower limb fractures one come across in our practice. Like my previous speaker told, in younger individuals, especially following road traffic accident, high velocity injuries, they will have a huge impact on their professional and personal fronts. So in order to treat them surgically, there are many factors which are involved, and one among them is the surgically approaching them. So before considering surgery on any patient with proximal tibia, the surgeon should be considering the following factors. He should know the fracture anatomy well. So for that, he should have sufficient radiographs, CT scans, and he should be able to classify them according to the standard classifications followed. And he should consider patient age, the activity level, the demands of the patient, and the comorbidities associated. We should also concentrate on the local factors like the condition of the skin, presence of any scars, surgical scars, previous incisions, and the soft tissue envelope around the proximal tibia. And like my previous speaker pointed out, compartment syndrome, vascular injuries are the notorious complication of these fractures. So we should know all these complications and when to plan for a definitive fixation or to stage our reconstruction procedures. Coming to the approaches, we can broadly discuss under two headings, the percutaneous ones or the minimally invasive approaches and the open approaches. The percutaneous fixation approach is feasible in the proximal tibia because of the subcutaneous nature of the bone. They basically work on three principles: indirect reduction of the fracture and submuscular or sometimes subcutaneous dissection and insertion of the implants. And the implants provide relative stability in this type of approaches. When you talk about indirect reduction, it can be either with manual traction on the principles of ligamentotaxis, or you can use a avofemoral distractors. Intraoperatively, one can use fluoroscopy to assess the reduction, or even arthroscopy to assess the joint surface restoration, and also to assess the intra-articular ligament injuries, and also to plan for the subsequent repair. Of course, percutaneous approaches have their own limitations. Like the previous speaker told, in severely comminuted fractures of shared skull type 5 and 6, where the fragments are displaced in multi-direction, it's not possible to always anatomically restore the joint surface and have a proper alignment. Then we have to consider more invasive approaches. In case of fractures with more than 4 to 5 millimeter of displacement or more than 5 millimeter of joint depression, one has to suspect entrapment of the meniscus. So in order to release the meniscus from the entrapment, we have to depend on the more invasive approaches. And of course, the posterior column fractures where the important major neurovascular bundles cross the fracture, we cannot afford to injure them using a percutaneous technique. So we have to depend on more open approaches. Coming to open approaches, the workhorse for any orthopedic surgeon are the anterolateral and the posteromedial approaches. These have been taught and we have been trained for these approaches since our training period. And the classical posterior approach also have been trained from our training period. The most recent ones are the Frosch posterolateral approach and the Lobanhofer description of posteromedial approaches to posterior column fractures. I'll discuss each and every one of them in detail. So coming to anterolateral approach, these are indicated in Schatzker 1, 2, 3 type of fractures. The main advantage is that it can be done in supine position. So there is a ease of imaging the fracture, and some of the cases where you need minimal maneuvers to reduce the fracture, you can afford to have a minimal dissection and tunnel your plate. The reduction of the fracture is at ease, and if necessary, you can do a submeniscal arthrotomy and visualize the joint surface for restoration after the depressed fragment is elevated. The disadvantages are that you can't reach the posterior part of the lateral condyle in some of the type 5-6 fractures. And we have seen in our practice that when you use a high profile implant, especially on the tibial head proximally, there is some prominence of the implant which irritates the patient. And if the facial closure after surgery is not proper, some people complain of muscle herniation of the tibialis anterior. Of course, when we use a long segment lateral plate, there is a possibility, especially middle and lower third of the leg, where the anterior tibial neurovascular bundle crosses to the front of the leg. Here I'll be showing a video of the anterolateral approach. First of all, I want to disclose that I've taken these videos online because my data with laptop was held up with my family elsewhere, and due to lockdown, I could not get them back. I've taken these videos from online. This is on a cadaver. I'm sorry. So the anterolateral incision you can plan from the femoral lateral epicondyle level. Then there is a curved incision across the Gerdis tubercle, which goes down lateral to the tibial crest. Should be at least 1 centimeter lateral. The skin incision along the skin marker. Then the deep dissection in the same line. Here, one point to note that the medial flap should not be elevated. The full thickness lateral skin and subcutaneous flap has to be elevated up to the deep fascia, all along the incision. After the elevation of the flap, you should feel for the deep fascia and incise the deep fascia lateral to the tibial crest, leaving a sufficient sleeve of tissue for later closure. Like I said, this, if we don't close it properly, there might be a herniation of the muscle, which may disturb the patient later. So the deep fascia is incised, and when you come proximally, it has to be subperiosteal, sharp dissection along the tibial head. Go on dissecting posteriorly. And in the proximal part, the iliotibial band is incised, but one should have a perception about the depth of the iliotibial band here, because inadvertently you should not open the capsule of the knee joint. So you elevate the flap, and distally you should be careful and make sure that you have a continuous flap from the iliotibial band to the lower level, so that the subsequent closure is easy and appropriate. So you dissect along the proximal tibial metaphysis subperiosteally. There's a place for you to reduce the fracture and then place your implant. Same way, the deep fascia is elevated subperiosteally anterior to the incision. Once you elevate and retract the deep fascia, you can feel for the lateral surface of the tibia, and if necessary, along the lateral surface, you can make a hole to elevate the depressed fragment. And the lateral cortex, you can make a hole and use instruments to elevate the fragment. And if necessary, to visualize the joint surface, feel for the joint line, and then incise the capsule, open the capsule, and once you confirm the joint surface, you can extend your incision proximally distally. You should not cut the meniscus inadvertently. So only coronary ligaments have to be incised. You should leave a sufficient tissue lower down on the tibia for subsequent closure of the reattachment of the meniscus. And the meniscus can be anchored with a suture in the periphery. So multiple sutures can be used, which can later be used for reattachment. So you can give a varus stress and you can look into the joint, elevating the meniscus superiorly. For a closure, you just have to reattach the meniscus and then close the deep fascia and then skin. Coming to the posteromedial approach, I would basically call it as a medial approach. Your incision is along the posteromedial border of the tibia. These are indicated in the type 4, 5 Schatzker fractures and type 1 Moore fracture where there is a partial condylar involvement on the medial side. Here again, the advantage is it is done in supine position and most of the dissection is subcutaneous. And in some cases where the medial condyle has to be fixed, you can do it in a minimally invasive way, where you can tunnel a plate on the medial surface. The disadvantage of this approach are proximally where the hamstring cross the tibia to their attachment. So there is a narrow field where usually the apex of the fracture is located. You will have difficulty in reducing it and holding the reduction. So, and for the assistant, in order to get the reduction, you have to hyperextend the leg and then give a varus stress, which is a difficult procedure in a obese patients. And for the surgeon, the trajectory of screw placement from posterior to anterior in a supine position is very difficult. Of course, there is a chance of injury to the saphenous nerve and vein during the incision or even during the closure. I'll show a video on the posteromedial approach. Again, it's a cadaveric dissection. So the incision is along the 1 finger breadth posterior to the medial border of the tibia. You can curve it posteriorly along the tibial contour. Incise the skin. The superficial fascia along the skin incision with a sharp dissection. Here we should be careful about the great saphenous vein. Usually the saphenous vein lies little anterior to the incision. So switch over to the blunt dissection and identify the great saphenous vein. Here you can see the great saphenous vein crossing your incision in the superficial fascia. Release it all along so that it is protected and retracted. Now for the superficial fascia, you should be careful about the saphenous nerve which goes along the superficial fascia. So inside the fascia, identify the nerve and release it all along. Protect the nerve, release it adequately so that you should not injure it while retracting by traction. So you can see the saphenous nerve being identified and released. So once you identify these two structures, you can safely retract them anteriorly and go ahead with your dissection proximally. Now you have to open the deep fascia. Once you open the deep fascia, you can see the posterior compartment muscles. And then in the proximal part, you have to feel the hamstring tendons, identify them, and release the sheath of the hamstring tendons carefully and retract them anteriorly. In some difficult reductions, you may have to cut the hamstring tendons, but later you make sure that you repair them properly. So once you retract the hamstring tendons and release all the soft tissues underneath the posteromedial condyle, you can visualize the entire condyle of the entire surface of the posteromedial tibia. Okay, coming to posterior approach, this is a classical approach which we have been studying and we have seen during our initial period of our practice. But nowadays it is obsolete with the invent of posteromedial and posterolateral approaches. Because of this long scar incision morbidity, the scar can have contracture and give pain for the patient. There is, of course, there is a risk for injury to the neurovascular bundle. So I'm not going to describe the posterior approach because it is obsolete nowadays. Other approaches with the invent of column concept for the tibial fractures by Low et al. In 2010. So the other speakers were already spoken about it. So the main problem is with the Schatzker classification, you look into the AP radiograph and you look into the fragments only from the front. You are not concentrating on the main fragments, major fragments, which are on the posterior medial and posterolateral side. So when you do a fixation from lateral aspect, the screw's trajectory doesn't have sufficient hold on these fragments. So we have seen so many times that the type 4, type 5 Schatzker fractures fixed very well, and within a few weeks, they have a varus collapse and implant failure. So with this experience, new approaches described by Lobenhofer and Frosch for posteromedial and posterolateral respectively have been into practice. Coming to Lobenhofer approach, it is mainly indicated for type 1 Moore fracture, especially involving the medial side. Also for type 5 Schatzker fractures, which have a medial coronal component, and also 3-column fracture dislocation like the one seen in this X-ray. This approach is done in a prone position with adequate support to the affected limb, and it has to be at a higher level to the contralateral limb for a better imaging, and also preoperatively make sure that you have true lateral view on the image. The advantages are that it has excellent access to the posterior column. Even it can be extensile with a horizontal limb of incision. You can reach posterolaterally. And with the position of prone, the medial side, the fracture is easy to reduce, and the easy implant placement, and for the surgeon, screw trajectory in the posterior anterior direction will be very easy. The disadvantages are injury to the popliteal vessels, and when you want to do a joint depressed fragment elevation, the limitation of joint visualization because of a narrow field. This is a video about Lobenhofer approach. Again, this is a 2-column fracture. The incision is a horizontal, it's a reverse hockey stick type of incision. You can take a vertical incision, vertical limb of this incision also. Now the deep fascia is exposed. Start incising the deep fascia along the skin incision to expose the medial gastrocnemius belly. You identify the anterior margin of the medial gastrocnemius, and by blunt dissection, retract it laterally. Underneath lies the popliteus muscle and the neurovascular bundle. So use a blunt Hohmann's retractor and then expose the popliteus muscle. So you can see the popliteus muscle attached, taking origin from the tibia. So incise the popliteus muscle from the origin and subperiosteally dissect and retract the popliteus muscle. So you have to clear all the attachment over the posteromedial tibia to expose the posteromedial condyle of the tibia. You can see the fracture line clearly with the fragments. You can reach far lateral with the extension of this incision up to the fibular head. So use whatever plate, the special plates, or even a T-buttress plate. Some people use distal radius locking plates for fixation, temporarily fix with a K-wire, and then go out with a permanent stabilization. Once you stabilize the fracture, all you have to do is get your popliteus back, suture it to its origin. This has to be done meticulously with little stress. Once you cover the popliteus, the implant is well covered, and close the deep fascia and skin. Now I'll come to the posterolateral approach described by Professor Frosch from Germany. This was a recent description in 2010. This approach is indicated for fractures involving the posterolateral condyle of the tibia with the depression. That's most of the type 5-6 Schatzkers, and also 3-column fracture dislocations. here the position is either prone position or a floating position, where you can maneuver the limb when you do a anterior window. So it's also called floppy lateral position. So here basically two windows are done. One is for the lateral compartment and another for the posterolateral condyle. This approach can also be modified when you want to visualize the joint for a elevated depressed fragment by doing a lateral epicondylar osteotomy. This is a video originally done by Professor Frosch. I'll be showing the same video. So this is a CT scan picture involving the posterolateral and posteromedial compartment with depression on the posterolateral side. The anatomical landmarks are fibular head, the joint line in a prone position, and there's a vertical incision 10 to 15 centimeter along the fibula. So inside the skin, subcutaneous tissue. Then you look for the biceps femoris tendon, open the tendon sheath, and on the posteromedial part of the tendon sheath, you find a common peroneal nerve, carefully dissect, identify, and release it. You have to dissect the common peroneal nerve till it crosses the fibular head. Now you can see the lateral head of the gastrocnemius and soleus attached to the fibular head. You have to release the soleus attachment from the fibula downwards, retract the lateral head of the medial gastrocnemius. Then you can see the neurovascular bundle. Here you're securing the common peroneal nerve. Then you identify the neurovascular bundle. This is a lateral inferior lateral genicular artery coming from the popliteal vessels. You have to identify, you have to ligate them or cauterize them. Then you expose the popliteus tendon underneath. Once you retract the popliteus, you are directly on the posterolateral head. So you clear the soft tissue on the bone, you can directly see the fracture there. You can dissect little downwards to the metaphyseal level where you can see your plate. You can see the fracture line clearly there on the posterolateral side. So this is the posterolateral window. Coming to the anterior window, so you have to do dissection subcutaneously in the front of the fibula, identify the iliotibial band, incise the iliotibial band superior to the fibula, and expose the capsule of the knee joint. Once the capsule is incised, submeniscally you can inspect into the joint. Carefully you dissect the capsule posteriorly for a better joint visualization. In some cases with severe depression, you will not be able to visualize the joint surface with this amount of elevation. So then you have to modify this approach by extending it proximally and exposing the lateral epicondyle of the femur. So this is showing the lateral epicondyle of the femur with the attached fibular collateral ligament and popliteus tendon. So you can osteotomize the lateral epicondyle to have a better exposure into the joint. So you mark your osteotomy, you incise the soft tissue or the lateral epicondyle, then using a sharp chisel, you just chip off the lateral epicondyle along with the fibular collateral ligament attached to that. So you take out release the fibular collateral ligament distally with the fragment. Now you can see the joint better and reduce the joint depressed fragment and then temporarily fix with K-wires. From posterolaterally also, you can elevate the fragments, temporarily fix them with K-wires. You can use, of course, raft screws to stabilize them initially. So intraoperative fluoroscopy shows a complete elevation and reduction of the fragments. Now you stabilize them with raft screws, and of course you can tunnel a plate on the lateral surface of the tibia and do a definitive fixation on the lateral column. And finally, you can reduce the epicondyle and fix it and check for the stability, valgus stability of the knee, and this is an intraoperative fluoroscopy showing a stable fixation. So finally, to end, knowing the complexity of these fractures and the complex surgical approaches we do, it is good for orthopedic surgeon to have an algorithm for these type of fractures, like what I've shown on this slide. So this will make our life more easy. The final take-home message is that the surgeon, while treating these fractures, has to be familiar with all approaches. You should have good consideration about the general and local factors before deciding on which surgery, which approach he is using. Should have a good preoperative CT images with 3D reconstruction. And of course, depending on the condition, you have to stage your surgery and for a successful outcome. Thank you very much.
Yeah, thank you, Brahmaraj sir. That is a very extensive coverage of the approaches. I think there are no questions regarding approaches as yet. Anyone who is interested to ask any question can do it through the OrthoTB portal. You can straight away send the questions to the speaker. We will perhaps move on to our next speaker, Dr. Ram Prasad, for his talk on approaches on proximal tibia fractures, my way of approach. After that, we can have some discussions. You have to share your screen, sir.
So Brahma, just exit.
Okay, just a minute.
Stop sharing.
You stop sharing, Brahma sir. And if anyone has any questions regarding anything, you can directly ask to the speaker. You can name the speaker whom you want to ask the question, or send it to OrthoTB portal, where we will get the questions and put it forward to the speaker. One question is there, shall I ask regarding the last, while we are on our way. The question was for the compartment syndrome. Do you depend on the clinical signs or you measure with some instruments? A query from OrthoTB. Dr. Uday, are you still there? Can you take the question?
Can you hear me?
Yeah.
I depend on the clinical signs.
Okay.
They're always on the clinical signs because pressure
have you ever
measurements,
used any instrument for doing it?
Yeah, there are instruments which are available, and many of them are with Zimmer had produced one where you measure the difference in the pressures. But I think the clinical ones are the best. I have depended on the clinical, and it has not.
Yeah, nothing better than the clinical signs.
They tell us that it is always better to do a fasciotomy when in doubt, rather than not doing one and getting sued for it.
Yeah.
Threshold when in doubt, go ahead and
has to be very low. Yeah. Thank you. Are we ready yet?
I'm not getting anything on the screen. Can anybody screen my screen?
I can see you, sir. We can see you.
So you have
to share the screen.
Yeah, you have to go
down. Down one, you got a green one.
Green button. Yeah.
Green button.
Share screen. Green button. You click on that.
If you have minimized it, you have to go for a wider screen first. Then you will get the share screen.
Okay. I'm minimize it. Wider.
Yeah. Just make
down,
it.
Down.
Wider screen.
Share screen.
More. No. Okay. I'm doing it. I'm at it now. Yeah, I got it.
Yes.
Got it. Share screen now.
Share screen.
Yeah. Click on share screen.
Share screen. Yes.
Yeah,
I think it will come now.
It's coming.
Now you can slideshows.
You can slideshows. Yes.
Go to slideshow.
Yeah.
Yeah, I think we'll start up. Can you hear me now? Can you? Yeah. Thank you very much. Thank you very much, Jagdish, and thank you very much for the Karnataka Orthopedic Association for giving me the opportunity to come into this. I think, thank you, Jagdish.
Thank you, sir.
Let me start off with this. I think our previous speakers, it can be a good oversight of both things. Brahmaraj had an excellent presentation and then like experts as well. So I think we'll start straight away with the classifications we know very well. I think I just give only a simple example of type 1. This is split fracture, we are all aware. The type 2 fracture is split and depression. The type 3 is I think the pure depression where the rim is intact. And the type 4 is that entire dislocation type of fracture, where we are more concerned about this fracture, where we know that the knee dislocated and the fixed point of the vessel is there, high chance of vascular injury. So whenever we find this knee dislocation with the lateral subluxation of the tibia, we see it quite often. We are worried about the vessel. Many times, I think even after the clinical palpation, any doubt, do not hesitate to do an angio, because of today we are living in a litigant world of litigant world where the delayed vascular injuries are very often in these cases. Even though you feel the pulse, the faint pulse with faint pulse, or with the Doppler pick up the faint pulse, do not hesitate. Go for angio, especially to safeguard ourselves. Go for an angio. And these cases, I always reduce the fractures first. Put a spanning fixator because they are mostly associated with swelling. So this gives us the time. This can reduce the fracture and relocate the knee joint also, and make sure that after the external fixator, I'll go for an angio and a seat in the same sitting. So it will have both those things in place. So legally we are safe, and then and we will reduce the knee as well. These are what we call this type 4 as the entire condyle fracture or a dislocation fracture. And this where shearing is going towards the anteromedial side. Type 4, type 5, it's a bicondylar type of fracture. And again, type 6 is the one where the metatarsal dissociation. So for the fractures, we are all aware of this instrument. Two good instruments I want to mention is the collinear clamp is one of the excellent tool, and usually the Petella clamp is also a very, very good tool. And even these are the Matha's clamp for reduction. I think they are the minimal invasive. They won't jeopardize soft tissue. And the bone graft always will be, especially when there's a depression, split depression fracture, there's a metaphyseal void. We always keep the graft ready, and then so that when you open it quickly, you can put the graft. Sometimes we always used to say, so if you don't take the graft, you feel like compromising, and then we'll avoid it. So keep the graft before, keep it ready to fill up the metaphyseal void. Support the elevated intraarticular fragment. I think the good tip where I think the elevated, the gauges are very useful for us to elevate and support them, especially when you do minimally. Then just some examples, we have a very simple fracture. Here only one point I want to mention is this fracture. Mostly meniscus will be free here, but we always put the plate perpendicular to the planar fracture. That is a simple thing, very simple fracture to begin with. But sometimes these fractures also has a metaphyseal extension, where this fracture's extension goes in the metaphysis, can cause compartment syndrome. Be aware of these fractures. I think especially this fracture, it happened to us. So we had to release it and we had to do a fasciotomy, and then later grafted. These fractures won't give any trouble most of the time. But here, unusually, this fracture has there is a lateral subluxation of the tibial plateau over the femoral condyle. I think this is not a pure split, but there is some element is there much more now here. So the third type, the second type is the split depression again. The split depression fracture, where the conspicuous thing is there's the overhang of the tibial condyle over the femoral condyle, and articular depression with the metaphyseal, with the metaphysis getting compressed. When you elevate, you'll find a big void there. So these are the cases where when you elevate it, you find a void, we need a graft to support it. The grafts are cancellous graft, iliac crest is very handy. We'll keep the grafts. Nowadays, I think people are using this hydroxyapatite blocks also. They're also equally well, but easy to use the graft, I think, consistently. I think today in our society, our country, people are not complaining much about the bone graft. Still we can do. Western world, I think they are not allowed to do. So I always keep the graft ready, especially when there's a void there, elevate them and pack them with a graft so that you have good support, then temporary KOA. And this is a similar case what we use. You can make out the crater, what you have, such a big crater. But without a graft, it's difficult. So I always put a graft. Graft incorporates much, much faster with the autogenous graft, cancellous, cortical graft. We all of us are aware. The meniscus is entrapped in these cases. Usually we elevate the meniscus and remove it from there, and then elevate whatever left or articular surface, and then we can reconstruct very well these cases. This is one of the good those cases is done. I think you'll get at the end of reduction, the valgus I think it is stable, the knee will be stable, so we'll get a good result for these cases. There's a type 3 fracture where the rim is intact, but mainly a central depression. There's little more than that. This is a posterior lateral, a very difficult area to approach. It's not an easy area to approach. One of the cases where we use the indirect technique for these cases. We use the curved gauge from the anterolateral approach itself, and we use here the advantage is we have a good subcontinental bone where it is a good young man. We had a good subcontinental bone. We can afford to do this. Old people you cannot afford to do, because when you punch it, automatically it will go and get into the joint. For this case, I think we could do that. I think that you can see this. We got a good elevation. We elevate it nicely. These curved gauges are useful for that. I think we had a good elevation. I think we could, in this case, successfully buttress plate with a normal buttress plate, and no special implants are used here because we have good quality of bone. And coming to the type 4 to type 6, these are the fractures most of the time. There are high energy fractures, and there's a lot of bleeding from the metaphases into the compartment. I think all of us are aware. We all commonly we see all these cases most of the time. And these are the cases where you end up with blisters, compartment syndrome. I think these things, and they come in time, usually when they come in time within 6 to 8 hours. We always go quickly, do a fasciotomy. Even if you come late, try to save the skin, especially hemorrhagic blisters when they are there. But the skin will definitely get a breather. Always release it. Mostly we do a one single fasciotomy, posterior lateral. If we do posterior medial, we'll put it in the line of incision. So 2 incisions and 1 more separate incision for the implant fixation is very difficult. Rheumatologist is aware of that. These things, we always couple the incision in the line of the previous planned surgical incision. And then these cases are difficult cases, always complication. Skin will always give a trouble for us. And then after the fasciotomy, we'll put external fixator first, stabilize the limb, then fasciotomy, and then we wait for a week time to settle down. Then only we'll go in. Because especially when the skin gives trouble after internal fixation, we are in bad trouble. That implant get exposed and sepsis will end up in. So one of the examples of the type 4, the middle condyle. This is the shear posterior, the shear fragments where the entire for the new classification, what they're talking about is this, the entire posterior medial as well as the posterior lateral condyle. There's a 3-column concept. I think the knee is sublexed completely. Whole of the tibia is completely anterior, sublexed anteriorly. The femoral condyles are lying posterior. And in these cases, the CT is very clear and an excellent CT representation of these cases. We always do this case immediately at the earliest possible time, take to the theater, reduce the knee, put an external fixator, the first step on the day 1, reduce them, and then relocate the knee, and then on, see, this is what we do on the day 1, and then we'll wait for some time. This gives the time. Then the CT is done mostly after the reduction, never before the reduction. That's what we do. And do not hesitate if you want any doubt about the vascularity. We'll do an angio for these cases. Especially one more case, I will tell you where there's a gross displacement of this posterior condyle and abut in the vessel as well. They'll be very useful for legally also for us, and to identify the vessel also very easy for us and how close we are. We'll be actually extra careful. So after a week time, I think this is the principle. What I just have put a diagram. To know the external fixator, we use the principle of ligament protaxis that automatically reduce the fracture most of the time by about 70 to 80%, and the knee as well is relocated. So this is I use the simple buttress plate. I don't use the locking plate because I feel the grip what you get, the hold what you get in these plates is much more better than the locking plate. The proximal tibial locking plates or even the combi hold plates are a little better. Otherwise, there are 3.5 screws with a small thread. The hold is not very good. I'm not really happy with it. I think we'll discuss about it after at the end of the session. I use the simple T buttress plate, a L buttress plate, or even a plain 4.5 standard plate, and that one little contouring. This contours very well and fits in the condyle, and it really abuts it. The principle, it relocates the knee as well with a good posterior capillary attachment to the fragment. I think just one plate will solve completely the posterior fragment. I think that this gives a good fixation for these fractures. I remove the fixate immediately on the table itself, and I'll use the gutter slab for a few days until the soft tissue settle down, and we'll start mobilizing on day 3, day 4. Another example of a type 5 fracture is a bicondylar fracture. The reason why I'm showing this is, see here, the entire lateral condyle is flipped out completely. It's lying outside the outside the femoral condyle. I think these are the emergencies where these cases will take them to theatre immediately. With the varus stress itself, we can mostly reduce it. But if we cannot reduce it, we have to open it up and put the lateral condyle back into the place. That's why I showed this case with the metaphyseal extension as well. I think the CT scan is very clear. I think that these cases, the medial plate, what you do, we use only the traditional normal standard 4.5 plate. I don't use the locking plate here. It's only tunnel with a small opening here. What Brahmaraj already showed the medial side. So we tunnel the medial side to preserve the soft tissue. One screw proximally mostly, and again only 1 or 2 screws with the strap hole. That will preserve the soft tissue envelope on the medial side. Laterally, it's the locking plate. I think with this, such a bad fracture, we can salvage this knee. I think we can reconstruct the knee very well. The ligament attack is the principal one, relocate the knee, and then time it surgery. And with this medial, with the dual buttress plating and the placement of strategically, these fractures can be reduced very well. Another example of this type, look at this fracture I showed you because look at this fracture, it looks very innocuous. We already had an excellent picture put on this fragment. See the CT, see the fragment which is posterolateral fragment. See how it is gone. It is embedded in the vessel as well. So I done an angio for this case. See how many fragments are there, the 3-column concept. See, there are 4 fragments, anteromedial, posteromedial, and anterolateral, and the posterolateral, which is completely dislocated. These are the cases where I think we all, the principal one is same, the reduce the knee, excellent fixator, wait for a few days, let the swelling settle down, then we'll go in. Then here we went in sequentially. And first we went in the posteromedial, put the plate, and posterolateral as the same incision we used it. We didn't take a separate posterolateral here. Same incision, we could reduce it. I used ordinary 3.5 plate, 3.5 semitubular plate. They are not special plate, ordinary plate, they're not locking plate. We had to use 4 plates and to collectively put all the full fragment, the 4 columns, not 3 columns here. So we could reduce with the small things here. We could reconstruct the knee very well, in spite of the bad fracture, with a strategically located plate, ordinary implant. But here we use the rim, the 3.5 reconstruction plate. We use it for the rim, anterolaterally. These are good results. I can show you, go back and show you such a fracture with a minimal, without soft tissue intervention. Where we use 3 incisions. Anteromedial again is the button, but only turning plate. We could reconstruct these knees with a strategically located incision without avoiding soft tissue, reconstruct the knee very well. We got a good result with a good range of movement as well. Another example of a fracture where you can see the posterior fragment, how it is. The knee is subluxed posteriorly as well here. Look at the CT films. Look at this fragment, how it is going down posteriorly. The principle of ligamentotaxis. We use external fixator. Even external fixator couldn't reduce this fragment. It's just lying there. And then we did an angio. Angio is embedded in the vessel as well here. So first is the posteromedial approach. That's what Proximal the Lobenhofer approach, where we use the normal T-buttress plate. Here, one thing I'll see, the slope is reversed here. The tibial slope is reversed here. But ultimately, we could reconstruct it well with a three implant, posteromedial, and the same incision we can put a medial buttress plate as well, a simple semitubular plate 4.5. You can use that to support the fragment. And the anterolateral normal T-buttress plate, we could reconstruct these fractures very well, especially when you plan properly. Then this can be, and the soft tissue also preserved. There are only 2 incisions for this. These are the type 5 type 6 fracture. I'll just show you one case of a open knee joint injury, where it is a runover injury. The knee is subluxed, patella tendon is reversed completely. And see this is such a bad injury, where the whole of the tibial, whole of the entire articular surface is sheared off, knee is subluxed posteriorly, the metaphyseal combination as well. But luckily the angio, the vessel is fully intact. And see the CT pictures, you can see the amount of displacement what it is. So what we did is the primary debridement on the day one and the primary internal fixation. Span the knee, span the knee. This knee the fixator will help us to handle the soft tissue, to stabilize the knee in place, which is subluxed. And then the day one internal fixation. We use only one implant. We turn the implant on the proximally with the open wound and reduce this. To the end of 3 months, the soft tissue has settled. The medial gastroflap has been done here with a skin drop. I will show you the result as well. See the internal post-op X-ray. See the result when it came in 3 months. Came in 3 months. You got excellent result. No, excellent soft tissue healing. Functionally really good. No extents are like. Of course, the metaphyseal void is still there, not fully healed. So my message for this tibial condyle fractures is, so especially for type 4 to type 6, soft tissue management is the most important thing. Timing of surgery is the second most important thing. And as well as buttress principle, normal buttress plates work very well for majority of the cases. Only the lateral buttress plate, I think the lateral locking plate has a good role. Even when you use that plate, you cannot hold the medial condyle securely. You need an additional medial buttress plate as in tunnel fashion or by post-medial approach. But locking plate is no panacea. It cannot solve all the problems. We have gone through all the problems of locking plate. We use only on the lateral side. So very important is strategically identifying the fracture, putting the buttress principle on wherever the key fragments are there, and overall that once the soft tissue is healed, early mobilization is the key for all our intraarticular fractures. I think with that, I think we can achieve good successful outcomes. But these are difficult fractures where soft tissue is the main concern. With that, I'll end my presentation. Thank you.
Yeah, thank you, Dr. Ramprasad sir. That was a very deep insight into the proximal tibia fracture. Thank you for sharing a big array of cases and your wisdom. There are two questions only.
Yeah.
One has come from Dr. Akram Ayaz through the Ortho-TB. The question is, can we do the Lovenhopper and the Frost approach simultaneously? And next question is, can we do the anterolateral fragment fixation with the Frost approach?
No, anterolateral difficult to do, but first one by one I'll answer. Usually when you do posteromedial approach, usually you can also do the lateral apposilateral approach also, but majority of the time we can reach with one approach, we manage majority of the time, we can use with one plate you can solve the problem. But rarely we need a second plate even. From the center of the tibia, we can span one-third tubular plate onto the lateral fragment. We don't need the two approaches. I never used both simultaneously. I use always the posteromedial approach itself is enough for me to hold both the fragments. The L buttress plate or a T buttress plate is adequate enough for you to hold both the fragments. In only one case, I have to use an additional plate separately to hold the lateral fragment. The one screw from the tibia is enough for you to support that fragment, which is a small fragment usually. So I never used both simultaneously, but technically, yes, we can use it. Soft tissue is not a problem there. We can use it.
Dr. Mallikarjun Swamy, you want to say something?
Sir, one question.
Yeah.
One question for Ramprasad sir.
Yeah.
So in all your X-rays, we were using all the simple plate as you showed.
Yeah.
Okay. Nowadays, we have a lot of the locking plate. The people used to tend to use it, are bound to use, or is it a market driven? Or do you think there is no need of any this type of screws for you, in the plate and screws for you?
Yeah. I think about what you are talking is very, very pertinent. Usually, what time and again we have gone through all the complete circle of using these market-driven or use that they are new good plates, they are very good plates, no doubt. They're all pre-contoured nicely. They're all pre-contoured. They are really good. But these locking plates, the only problem for me will be the locking plates are not giving the adequate grip, adequate purchase on the bone because they are small screws. And second thing, with the newer variable locking plates, they're a little better, but they're quite expensive. I don't think they are really so much worth it really. When you can solve the problem with a simple plate, which are 1/4 or 1/5 cost, I think, and then more than the cost also, the purpose what we are using it, I think is very well. That they serve with the normal plate itself, provided with them strategically placed on the buttress principle, supporting the key fragment. They are working very well. except the long lateral locking plate. I think that has a good place, no doubt about it. That too, I never use the locking screws in the diaphysis. I use only the locking screws on the proximal metaphysis, but the remaining all, I use the normal screws, normal ordinary cortical screws only. I'll use it. So locking screws are quite big, purchase is less. I think the principle I feel, I think it's a limited place. I don't think we need not overdo those things. Whenever you want, use it, no doubt. But I think we can solve the problem, majority of the things, with the strategically placing a normal plate itself.
Sir, this is Dr. Mohan.
4.5 system or the 6.5 system?
4.5.
Hello.
4.5.
Dr. Mohan.
Yeah,
Hello.
a question for Ram Prasad, sir. Sir,
Yeah.
one of the just a curious question, because when you use a 6.5 mm cancellous screw in the proximal condyles, usage of other screws becomes a challenge because you will have.
Correct.
So one of the reasons why locking screws were introduced 3.5 system was to have that ability for us to play around with the screw trajectory.
Yeah.
What is your thoughts on that?
Yeah, you are sharing the screen still. I'll show you one X-ray for that. What we use strategically when you place the screws, I think that will be useful for you. We can avoid that. I'm just showing. Can you see my screen again still?
No, you'll have to share the screen.
We are seeing your face.
You'll have to share it.
I think.
We can see you, but you have to share the screen.
Screen sharing has to be enabled.
If you have minimized it, you have to maximize it, sir. Make it a full screen, and you can go for a screen sharing.
I not touched anything. I not touched anything. I don't know what has happened. Let me just see. I'll minimize the presentation. I not touched anything.
No, probably you have to.
I can see the zoom one.
Yeah, you can see the zoom. But,
if you go to zoom just down, there will be a thing.
now down you have a share.
So
screen.
down,
Green share video.
can you see a share screen, green arrow?
Yeah. I'm just. I got it now. I'm there.
Yes.
I'm there now. Yeah. Now I can see my presentation now.
Yeah.
Yes.
You can see here. Usually, what commonly what happens here? You see the proximal medial screw. This will be the most what you said exactly that is going to happen. But when you see the medial screw, we'll keep it a really high subchondral. The locking plate cannot go mostly up there. So locking plate always stays about 2 centimeters below the subchondral bone. So usually, I think when you use this one single screw medially, that won't come in your way. And locking screws are always about much lower the area. So they are holding the posterior middle fragment. We can strategically place it. We can avoid that problem. That is a technical problem, I fully agree. But we can strategically we can avoid it also. Okay, am I clear now?
Yeah.
Yeah, so I have one question.
Yeah.
Dr. Ram Prasad.
Yeah.
I have been using the dedicated posteromedial plate.
Yeah.
Where the screws go away from the joint.
Yeah.
So like here you have shown.
Yeah.
It goes away from the joint.
Yeah.
I don't know. They are available both in the Indian as well as the Indian ones are quite good.
Yeah, I fully agree. Fully agree. They're very good. There's no doubt about it. See, this what I used here is an ordinary simple plate.
Exactly.
A simple plate. And that plate is also very well controlled, very well designed. But the grip on that, especially the 3.5 screw, it is not really great. Not really great. But that's why I stopped using that. Look at this. This is a 4.5 screw. This is a same 6.5 cancellous screw, an ordinary T plate. This is equally serving the purpose for me. And that's why I start after using that. The screw doesn't allow me with freedom, and it has not the purchase what it gives is not so great. That's why I stopped using it. I have those plates.
There has been only one issue.
Yeah.
Whenever I put these posterior plates.
Yeah.
Always I feel anxious whether they will back out.
Just
behind them you have the neurovascular bundle.
Correct. But so, more than this screw, these are going to hold it nicely.
Yeah.
More than the proximal. Even if you want to avoid it, nothing will happen.
Yeah.
Nothing will happen. Even if those experiments are, I fully agree with you. What is practically absolutely correct. But these two screws distally in the metadiaphysis are more hold rather than this screw, especially when the combination is there. Correct. But when you are don't put that. Don't put that. No, nothing will happen.
Yeah.
Nothing will happen. Sure.
So one last question, sir, for the sake of the audience.
Yeah.
What is your thought on, say, in a badly comminuted type 5, type 6 fracture?
Yeah.
Your thought on decision making for the midline approach?
Yeah, midline approach, I stopped using it. We were using it before because, first of all, our dissections are medially, we are right on the vessels there. So as far as possible, the teaching for us, our seniors told us, don't see the vessel, don't touch the vessel. And second thing, this new, the Lobenhofer's approach is excellent, really, where it's very simple and we put the patient prone, very fast and quick. And then we don't see the vessel, we don't go near the vessel. Normally, we are not supposed to use the humans especially for that approach. We are supposed to use only the Langenberg. Of course, we use the humans routinely, the humans routinely. But I feel when we are near the vessel, it will cumbersome, it little bit, when you are using a drill everything, it is a little bit difficult for us. This approach, especially the posterior medial approach, is very good, which is where we are far away from the vessel, you don't see the vessel, and comfortably can finish it faster in about 20, 25 minutes, you can finish and come out. That's why I avoid midline. The same thing what you can do with the midline, we can do with the posterior medial approach, the approach itself. But as you do more, you can easily find out that the T butterfly is a big plate. L butterfly is also equally big plate that is going to cover the whole tibia for you.
I'm sorry, my question was from the anterior side, especially when we know, because when the patient is at risk of arthritis, because in the future.
I know, I fully agree. We had some bad experience. We were using this thought was there. This was the thought what we were. I don't know, Jagdish, you remember this one? This approach was there initially. Germans prompted this approach for us.
Yes.
Anterior medial approach for the tibial fractures. We had terrible experience in these cases with the synovial leak post-operatively. When there is a synovial leak, and what happens is that it is terrible to control, and sepsis will happen. So from that time, we stopped this. It's very good. Technically, it's very good. It is logically looks very, very safe. But some reason, the synovial leaks are more prone with the anterior medial approach. And because the whole thing is, whole of the soft tissues are sheared off. The synovial leak, if we have difficult to control this, then we have to put a gastroflaps only to control the synovial leak, and sepsis will supervene. So I'm afraid of doing that. We were doing it for some time. So what I'm talking is about in early 2000, late 90s and early 2000, but we stopped it completely because of fear of synovial leak. We had practically the problem. We got over it, but we stopped using it.
Okay.
Dr. Mohan, regarding the posterior midline approach, initially for about a few years, we were taking the help of a plastic surgeon who would do a dead midline approach and dissect the vessels, neurovascular bundle, and we would go and fix on either side. But the problem we had was healing of the tissue healing was quite bad. So once we shifted to the Lobenhofer and the Frosch approach, literally the midline approach posteriorly, we have given up longer.
No, I completely agree, sir, because with the Lobenhofer approach, I think there's no need for the posterior midline.
Correct. Very good.
Can I make a point? In the posterior approach, the scar crosses the joint line vertically, perpendicularly.
Correct.
So it gives a lot of post-operative pain, and the scar when it contractures, so patient will have limited extension.
Yes.
When healing is the problem, Raj, it won't heal that area.
Yeah.
It does not heal.
There is one last question.
Yeah.
Do knee aspiration decompress? Yeah, hello. Are you audible? Am I audible?
Yes, you are. Yes, you can.
Yeah, knee aspirations, can it decompress compartment because metaphyseal fractures communicating into the compartment? Am I clear?
Yeah.
I think
can knee aspirations help in decompressing the
will knee aspiration help decompress the compartment?
Yeah.
That's the question.
Yeah.
To me, it is no.
it is
no. I don't think it. Knee aspiration gives definitely some relief for a short while. Definitely, the bleeding is going on, but that cannot categorically. It cannot decompress the compartment. Absolutely.
Can I ask question?
Yes,
please.
I'm raising my hand since long time. Can
I? Go ahead.
Okay. Like Malikodan Sami sir. Tell me, sir.
Sorry, because I don't disturb you people. I am raising my hand.
No. Your video is not there.
Sir, your video is off.
We can't hear you. We can't see you.
Your video is off.
Cannot see you.
Now we can.
This is for Dr. Ram Prasad.
Yeah, please.
I would like to ask you, sir, in your nice presentation and type 5 and type 6 fractures.
Yeah.
Do you routinely do knee spanning and do CT, or just CT?
Yeah, whenever the knee is subluxed, whenever the knee, two clear indications. Whenever usually the knee is subluxed in these cases, there are high energy injury, high velocity injury, and these cases there will be automatically swelling. If there is no swelling, if the knee is not subluxed, we don't put a fixator. When the knee is subluxed and the swelling is reasonable enough, we require fasciotomy, or we sometimes may not require fasciotomy. But still, when the swelling is substantial, and then when the knee is subluxed, we always put a fixator. And there are two advantages. It will, number one, it is a ligamentaotaxis, reduce the fracture to majority 70%. And second thing, especially the today's private practice, to keep the patient in the bed is not easy. With this, with the knee spanning fixator, a patient can get out of the bed, they can go to the toilet, they can stand in a parallel bar, they are comfortable in the chair rather than lying in the bed. Of course, we'll elevate the leg in the bed, but it's really great comfort for the patient.
And second question is there, sir, when you are planning for decompression, when there is a compartment syndrome, you go ahead with the fixation or only compartment decompression?
No, we'll only on the day one, at the earliest possible time, we'll decompress it. And we'll only decompress it mostly posterior laterally, all the three compartments differently. Fourth compartment, I don't say everything because many people will do. The deep compartment is not easy, it bleeds a lot. And then we only decompress it majority of the time, unless the case what I showed you, one case is that the tibial condyle is flipped. Unless those cases, I just come back to the case again. Can you see my screen? Can you see my screen?
Third point is that I agree with you.
Yeah.
Regarding management of the tibial condyle fractures is a right approach and proper anatomical reduction if required bone grafting.
Correct.
And implant is a surgeon choice.
Correct.
But if it may be locked compression plate, it may be simple buttress plate.
Correct.
I agree with you, sir. Thank you.
Correct.
Thank you.
Thanks.
We'll now move on to the next two presentations, the complex knee injury, multi-ligament one-step approach by Dr. P.C. Jagdish, and after that, post-traumatic arthritis joint, HTO for joint preservation by Dr. Hussain Sabnis. Dr. Jagdish, are you ready?
Yeah, thank you. I'm just ready. I'm just going for a screen sharing right now. Yeah. So this is a little bit, apart from the proximal tibia fractures, why we wanted is most of the people, when they come to the fracture proximal tibia, they will invariably have a doubtful about what have to do with the ligaments and all. But you know that, when there is there's a classification which shows that, type 5 or type 6, by the knee dislocation, which I'll come later, there is an associated ligament injury with the fractures. But believe me that, when you're treating these fractures, probably the ligament itself will come into its place. You don't have to be worried about it. It will come into place, except in a few cases where you need to address in the very, type 1 fractures or type 2 fractures, associated ligament injuries will be sometimes will be present. And we usually come, in this type of scenario where the knee is very much completely unstable. It is unstable in all the directions. What we can call is the anterior, posterior, and the medial, lateral. Everything is a global instability. What we call about it. So when we get these type of the cases, so how we are going to approach about it? As you know that the definition of the multi-ligament injury per se itself, you have at least a 2 or 4 major ligament structures. That is an ACL, PCL, posteromedial, or the posterolateral corner. And the terms dislocation and multi-ligament injuries are often a little bit, interchangeable. They're a little bit misleading. Knee dislocations can result and often results in a multi-ligament injuries, but but all the multi-ligament injuries cannot call as a knee dislocation. This is one thing which we need to know about it. So a knee dislocation, when it is typically, it is characterized by rupture of both the cruciate ligaments, but when with and without associated with grade 3 medial or collateral ligament injuries. It was a Schenk case who described the classification for the knee dislocation in 1994. He shows that the one is the injury to the singular cruciate plus collaterals. 2 is ACL PCL with intact collateral. So it's only an anterior posterior injuries. And whereas in the 3, it is same plus 2 plus medial collateral ligament will be there. In type 3L, it's L is there, where the lateral collateral ligament is there. And type 4, there's an injury to the ACL, PCL, MCL, and fibular collateral ligament. And type fifth one, which is talking about it, is dislocation plus fracture can happen over there. And how to handle of these cases, is it like you have to address in a single stage or in multiple stage procedure? I'll come to the case scenario one. This is a young lady, 23 years lady, who was, when she was traveling a two-wheeler, had a slip, and the whole of her two-wheeler fell on her vehicle. So on her leg. The mode of injury was very clearly telling that there should be PCL mid-substance tear, and plus medial collateral ligament could have been torn. But we were not. The MRA also was there, but sorry, though the MRI was corrupted, I could not able to show it over here. When we see our examiner clinically, this in the operative OT, this is how we know the leg was going. It was going a very much completely outside. So the medial collateral ligament and the posterior medial corner, everything has been ruptured. And as well as the same thing, when we did an exam here, the anterior posterior translation was very much evident. So in these type of cases, we have to think about one single stage approach or a multiple stage approach. Of course, when we are doing this, you have to think care about the posterior capsule. If the posterior capsule is torn completely, better to delay it for some time, say at least for 2 to 3 weeks. Invariably, it will happen. There will be a tear. There will be a tear of the posterior capsule. When extensive injuries like this will happen. But I have to take this case, because of something which they needed, the patient wanted to have it, and imagine that that's a posterior cruciate ligament which I had, which is seeing it completely debrided, and this is the technique which I did in all inside technique. I took a drill with this retro drill came and retrieved it, and the PCL is reconstructed. So these type of scenarios where when there's a multi-ligament approach is there, when we are doing a PCL, I will go through the posterior medial approach. There is a posterior medial portal. When I take a portals, what happens is here, the extravasation of the fluid will happen. In the initially, it will be very difficult for you to visualize, but will take some times and always take a precautions to avoid the compartment syndrome. If you find any compartment syndrome, better you usually what we do from the tibia to the posterior, the popliteal region posterior, we drill it better so that whatever the fluid which we are going to put it over there will come extravasate and will not cause any problem for us. So that was the posterior cruciate ligament which I showed, repaired it, reconstructed it. And this was a very surprise for us because the MRI was not giving a tear. In fact, it was not a good MRI. It was not from a good center. So we had a little bit of surprise on table. So luckily we had the meniscal scorpion, what we call. It is a little bit of tear with a very few, the bony pieces from the avals from the tibial attachment of an ACL. I could able to grasp it, the ACL. We needed only the cape to the ACL to its footprint. So taking a bite over the ACL. Then for this year, I use a fiber wire, the zero fiber wire, to where 2, 3 to say the zero fiber wires to lock it around, and then make a tunnel at the footprint, and bring that whatever the bite we have taken through the ACL and put it down to the tibial tunnel, and in anteriorly you're going to fix it with any of the washer which is available. So once if it is done, that's sorry, there's a meniscal, this patient had a meniscal root tear also. The video has been corrupted. The meniscal root tear also, she had a completely, it was an avulse from the medial meniscus, medial root. It was a type 3 to type 4, type 3 laparotic and we had to repair it completely and back it, fix it into the point, because this is very important to make her, arthritic free, at least for at some stage of an year. So there you can see there is there's a button over there. I use a regular washer over that because for the medial meniscal root repair, I used a 4.5 mm, which normally for this patient, which usually I used to 6 mm. So here when I drill a 4.5 mm and it's widened it over there on the mouth of there, and the meniscus which I did, I taken it out and I pushed it, I retrieved it through it and suture it with a suture disc and all. She had a medial collateral ligament, which I told over there, and this it was at the tibial attachments. So there was a wide, the footprint of the medial collateral ligament that can be better used stabilized with using a staples. So you should have, when you are doing wheel all these type of cases, the multi-ligament injuries, you have to better keep all the armamentarium in your basket when operate in your theater while dealing with this type of cases. So, and the third month of follow-up, she could able to bend it, because these are the cases when they will go for the arthrofibrosis, because cases have been reported that, when you're doing it in early, evidences of arthrofibrosis can happen. We can see that still she is not able to extend completely at the end of 3 months. So vigorous completely has to be given for that to make it into a complete extension. And I checked the medial lateral and medial valgus, the stretches, could able to see that, it is well, uh, you know, stability was there. The medial lateral stability was well over there. So this is at the end of 3 months. I mean, at the end of 10 months, the patient was having a very good flexion completely without any evidence of fibrosis. And you can see over here, and here she can able to hop to make her get with confidence, so that how she can be as normal as a thing. So once you give the patient confidence, I think it's a good one. And we'll take a case 2 scenario over here. And he's a Mr. 40 years old young guy. He had an injury and he had been to another hospital in a local Bangalore city. But they had to tell him that, we are not going to do repair or anything right now. It is a completely, all the ligaments are torn. You will not get back to your all original ligament. So better you stay away with all the same ligament torn which you have got it, and later you need a replacement. So fortunately, we've seen us, and this is what he had. He had an ACL, PCL, lateral collateral ligament, MCL, plus bucket handle, lateral meniscus tear. You can see that if an X-ray shows that there is nothing, no fracture, but you can see there's a depression in the lateral condyle of a tibia. Okay, and that is where the lateral collateral ligament was completely avulsed from its attachment, and this also gives an indication for that there is probably it could have been an ACL tear would have been clear also. And MRI showing over here, can you see the medial collateral ligament? It is detached from its tibial attachment, and lateral completely there is depressed with an elevate with the lateral collateral ligament complete tear. So these type of cases, when you come across, it is always time has already gone. It is not an acute. So it's already she presented a 1 month later to me. When he presented 1 month later, I was surprised to see that when I entered the scopy, the meniscus was completely, it was a bucket handle thing. The bucket handle, and it was completely struck over there, which was not reducible in the beginning. So I have to take out all the soft tissues additions, which is surrounding the lateral meniscus at its root and its body, and make it free. But still, when I try to put it into its place, into its plateau, it was not sitting properly. It was still, the lifting up. That means that at the root of the attachment of the lateral meniscus, there was some soft tissue adhesions was there, and was not allowing for the meniscus to sit into its proper position. Because once if this sits only, then I can able to repair the lateral meniscus, which is very important for him to get back to his, the pain-free knee, or non less an arthritic knee in the later stages. So extensively, the soft tissue has been debrided over there. You can see that using radio frequency ablation. And if I feel that when it is happy, so we can just, I'll push it back to this place, and to its place. Still, it is not sitting over there. You can see that. And one side, I'm using the probe to keep it in its place. And once it has removed the soft tissue, it is sitting in its place. But still, you can see that in the medially, at its root attachment, it is completely turned inwards. That means that that soft tissue somewhere it is not allowing for the complete reduction. When I use the probe and just lift it up, you could able to see that the tissues which is slowly get released when I pull that up. So this is what I wanted it. So completely there is a root as avulsed and the whole of the meniscus completely flopped with reversed and reverse locating. So I had to repair, using a hybrid techniques, which is an all inside as well as the inside out technique, which is little sometimes inside out technique and the lateral meniscus it quite a little bit challenging when you're doing it. So I'll take a less mini incision for this inside out technique. And this is what clinical, the extra outside picture. You can see that, the lateral collateral ligament, how it was completely avulsed from it. I had to attach it over there. I used a staple. I said it was little but attached with this bone. I could easily put a staple and a small cancellous screw has been put to get back its, the lateral compartment to its position. And for the medial meniscus state completely, it was down here, so I had to completely take it out from there and did a cross suturing over there and bring it over there and tie it over here. Of course, that day I did not having the similar one, another one of our staples. Another one staples would have been much more helpful for us. So having it, keeping it in all armament is very helpful in this stage. That's what I wanted to convey this message. If you see it clinically, this patient, after seen after nearly 11 months, I believe, he could able to have a full flexion and a stable knee without any deficits, and still he has not done his homework with the hamstring. So he had a little bit of no flexion. He had to use his hand to get a completely knee flexion. And when you see it, the mediolateral stability, so it was almost all it was completely stable. You can see that when in the top position is just going to do a lateral mediolateral stability. So these type of cases, taking a decision at the right point and making it, fixing it to all the ligaments, if you can, in one stage, it's always a better. And stability both anterior posteriorly and lateral. So the case 3 scenario, I'll take it, where the patient has got an ACL avulsion, PCL tear, and MCL tear as well. So in these type of cases, you can see clinically, this is the first video which I showed about it. He had a ACL avulsion, PCL tear, plus medial collateral ligament tear. So I had to fix all these things, same thing at one stage itself. So if you see him, he had a little bit of arthropfibrosis. So that is the reason, even at the end of 11 months, he is not able to do little bit flexion. But this is only a rare cases which we still get this. Our rehabilitation protocol has to change always. You cannot keep it a protocol for every patient. Every patient should be individualized. So if needed any lateral ligament reconstruction, I'm not going to do that. So what is the advantage and what is the disadvantage of it? So the advantage is, you can sit in one stage and you can fix all the ligaments together. The disadvantage is, of course, technically it will be demanding and graftability could be a problem. So I will have it usually the BTB for the ACL and for the PCL. Since I do it in all inside, I will have an hamstring. And if at all, if I didn't get anything at all, if at all, if a medial collateral ligament needs to be addressed, usually I'll go for a peroneus longus or even quadriceps, for this. And there is also a greater risk of an arthropfibrosis, which can be dealt by individualizing the patients. So, and two-stage procedure only the advantage is, you can stages yourself, plan it, but only the advantages is it will take your treatment bit much longer. And suppose if there is any infection there, your second stage will become totally contraindicated. When do you open to injury? It is when there is an associated fractures or an arterial fractures or arterial lesions. Lateral compartment is unrepairable. And of course, if you aborted your surgery when doing a case, if it gets completely compartment syndrome. So a lot of technical problem can happen leading to you need to abort. So conservative or surgical, it depends upon how you got it, your technicality and timing of surgery. I said, usually 2 to 3 weeks. I do it all completely. Whether it is repair and early, if you do in early stages, that is an acute, you can some of the things you can repair it. If you are doing it little stage, you have go for a reconstruction. And mobility is, I individualize the patient. I said, The patient has always to be individualized so that you can avoid an arthropfibrosis. Associated injuries always should be addressed, like in cartilage or meniscus, and extraarticular thing like fractures, spinners, and neurovascular things. If there is an insufficient primary repair, there will be a failure. So if you don't have a graft proper, definitely it's going to fail. So all these to be, you have to have in a proper and getting it for a successful your ligament reconstructions. There are a lot of articles have come, from beyond 2015, showing that, especially from the latter day, he's got extensive the study on that multi-ligament reconstruction, showing has got extremely good results in getting it. So what you have to do is you have to avoid your avoid tunnel convergence when you're doing it, and tension sequentially without not taking it. If you're doing it in a PCL, you all fix it all properly for ACL, PCL, and then go for a PCL, then ACL, and then you have a 30-degree, you can go for a medial collateral ligament repair or a tightening, reconstruction. So this is how all the tunnels, if you have got it, shows over there. This is a PCL. If you have got it, goes well down over here from the tibial plateau, you won't be a problem, and it will be almost a little bit into the mid part of your shin near. Here, this will be the ACL one. It will be almost towards the median. And this is how it shows when you do it in a CT scan, how the tunnels appears. And tensioning sequence is shown. So to avoid as much as possible, you have to have your, arthropibrosis, you need to plan up your surgery very well and individualize your patient for rehabilitation. So every patient should be individualized, okay, when you're doing it. And correct treatment is determined only after clinical examination. And if you have got a proper MRI with the stress radiographs and neurooscillation complications have been, you should rule out before taking up any cases, because we already seen that before, in your proximal tibial fractures, the role of doing it, arterial cramps is very important. And of course, other complications like a polytrauma compartment should be corrected, and you should always have a age weight of the patient properly for a better results. Thank you.
Yeah, thank you, Dr. Jagdish. That was pretty comprehensive. We know you as a wizard with the arthroscope. We'll move on to the next presentation. We have around 8 minutes.
We have time to ask.
So the next presentation will be post-traumatic arthritis.
Somebody is asking Dr. Neeraj. Dr. Neeraj?
Yeah.
Dr. Mallikarjuna Swami, I believe.
I raise my hand.
Yeah.
Yes, sir.
To Jagdish only.
Yes, sir.
And in multi-ligamentous injury, and when will you plan your procedures, copy procedures?
Sir, usually when I did completely and I investigated with an MRI, everything, I'll plan up if the posterior capsule is not torn, because that is the one which is going to decide. But invariably, it will be present in most of the cases, except in few cases if they've got only ACL, PCL. You need not expect the complete tear of a posterior capsule. When I'm addressing all these posterior medial MCL and all, usually I'll keep it for for 2 weeks, minimum 2 weeks, so that within that I can plan up very well for all that. By that time, the swelling would have been healed, and whatever the plan which I wanted, I can plan it very well.
Usually we teach 3 weeks rest, and followed by you can do the procedures. What you will do exactly for 3 weeks?
So 3 weeks, I just ask the patient to keep elevation and cryotherapy, ice pack, ice fermentation, which really helpful in getting the swelling very down completely. And once if you get the shrink, once the swelling has subsided, and once the skin creases starts coming, then immediately I will tell the patient to come down and get ready for the surgery.
By the time we expect collaterals may heal.
But collaterals may heal, but again we are doing it, the flexion, and we are going for hyperflexion. That definitely they're bound to get retail easily, very good. So you need to have repair it again when it happens.
And lastly, when it is associated with meniscal injuries, you prefer raphe or meniscectomy?
No, I never do a meniscectomy, especially when it is repairable, because whatever I showed over there, it's all completely extensive.
Put your all effort to retain the meniscus.
I'll take all effort to put to retain the meniscus, because that is what we wanted to do good for the patient.
Thank you. Thank you.
We can move on to the next talk, the post-traumatic arthritic joint, HTO for joint preservation by Dr.
Bhushan.
Bhushan, are you ready?
Can you hear me, guys?
Yeah,
Yes, yes, we can
cannot
hear
see
you.
your screen.
Hello. Yeah, sorry, I lost you for a
Very
second.
good. Yeah.
So this is the final talk of a good meeting. We have had a good discussion about how a tibial plateau fracture happens, what we can do to sort it out, what to do with the ligamentous injuries which may or may not be associated. Now let's talk about what if someone presents to you with a deformity or arthrosis following a tibial plateau fracture. So to begin with, osteotomies is a very powerful tool. It's a versatile tool. You can play with all the three planes in terms of deformity management. You can play with the coronal plane, the sagittal plane, or even the rotational plane as such. The main purpose of osteotomy is to unload the damaged area of the knee, detension the ligaments, improve the range of motion. It can be an adjunct to other procedures as well. Now, the key here is what bone and which correction. And that's why we need to know all these funny angles that we talk about. We need to know the MPTA, which is the medial proximal tibial angle, and the ALDFA, which is the lateral distal femoral angle, or MLDFA, which is the mechanical lateral distal femoral angle. And these angles both are roughly around 87 degrees. And if you look at the tibial angle and the posterior distal, these are around 152 degrees. And these are key in deciding what kind of deformity you're dealing with and what type of correction you're required to do. The mainstay of your management, of course, is CT scan and a scanogram, which is standing scanogram, which shows you what kind of correction and what level of correction is required. Now, a standard HTO is fairly straightforward. You make a cut in the bone, you stag, you surgery as such. You can play with the slope in cases where there is a damage to the ligament and you are not planning to do a ligament reconstruction. So you can flatten the slope in cases of ACL rupture such as this, or you can increase the slope in patients who have PCL deficiency. It's very classical that there is a femoral fracture and PCL deficiency is missed. So in such cases, a correction of coronal plane along with a slope change works quite well in getting the patient stabilized. Sometimes you can change the rotational alignment as well, where you can just change the like in this patient, and that way you can get the rotational deformity corrected as well. So it's a very powerful tool. What we are talking today is post-traumatic knee deformity and arthrosis, which is quite different from a standard MCOA correction HTO. Now, we have heard a lot about the tibial plateau fracture classification, and we know that the most common fracture is a lateral fracture, and it sometimes is a boon in patients who have early or moderate medial compartment arthritis. What we call is a nature's own treatment. Because of the lateral collapse, the deformity gets auto-corrected, and those patients are generally quite happy. So quite a few times for patients who are in their late 40s, early 50s, if you just leave the fracture with slight amount of valgus correction, they're quite happy if they have pre-existing medial compartment arthritis. Things do get interesting though when you have a medial plateau fracture which is malunited or maltreated. You have a lateral tibial plateau fracture with a complete collapse or with associated ligament deficiency as such. I'm going to talk about a couple of cases to illustrate my point. Let's start with a case. This is a 28-year-old lady who fell off a scooty and twisted her knee quite awkwardly. For some reason, the scooties are quite prone to cause knee dislocations and knee injuries in India, especially in ladies. So everyone has to be careful with scooty patients. So she twisted her knee quite awkwardly, had immediate pain and swelling in the knee, was unable to weight bear, and was seen by the local orthopod. The history is that she underwent open reduction interval fixation with a transverse. Please bear with me for the quality of the X-ray, but this is what I got. So this is the kind of a fracture she presented with. It looks quite innocuous, but if you look carefully, there's a PCL avulsion and there is a medial tibial plateau fracture. And we heard in the classification, medial tibial plateau fracture is a slightly more high velocity injury as compared to the other ones, and that's why it comes at number 4 in Shaskar classification and doesn't come after number 1. So the classical way in which it's described this is a fracture dislocation of the whole knee because of the forces that go through the medial compartment and the collapse. Now, all these fractures need to be fixed with a buttress plate, and we had a brilliant presentation about it. And this buttressing is a key to stop the knee from collapsing. Unfortunately, she underwent this so-called rim plating. There was a question about it as well in the chat. So a transverse plating of tibia using a recon plate is a known procedure. It has no buttress effect, and indeed, if you see on the X-ray, there is a small spike of tibial condyle on the medial side, which has been missed. This may look stable on table, but is known to slip quite often. So this patient now presents to me 5 months post-operatively with inability to bear weight, with a large transverse scar, as you can see here, on the medial proximal tibia, with a fixed posterior subluxation, with a stiff knee with a range of motion from 10 to 100 degrees. And to add to the insult, there is a varus deformity as well. So this is how things start getting tricky when you get neglected or maltreated fractures of proximal tibia. Now that's her scanogram at the time of presentation. As you can see, the knee is subluxed. It's a fixed subluxation, and there is a FFD of about 10 degrees as such. Now, someone who's 28, 29 with a knee like that is kind of a disaster, because you know, if you don't do anything, she is going to head straight towards a knee replacement sooner or later. So what are the options that we have? So the problems we're facing now are fixed subluxation, both in coronal and sagittal pain. We have a lateral subluxation of the tibia, and we have a fixed posterior subluxation. We have a varus alignment due to medial collapse with a stiff knee. So all of these will need to be solved. What are the options we have? We can do soft tissue release to correct the deformity, followed by application of a X-fix, which it's sort of a standard treatment. But what about the deformity in the bone? So we need to do an extra intra-articular deformity to correct the medial collapse. For the PCL avulsion, we might need to do a slope changing as well, or we can do all of these together without the X-fix by doing a HTO along with all of the soft tissue releases, and play with the slope at the same time to correct the deformity. So it's a slightly complicated matter. Let's see how it goes. So that's the medial incision that you see on the knee. A transverse weird incision. I would generally not recommend this incision for anything. You can see the knees sublux posteriorly, which is slightly better under anesthesia. So it's there's still some hope that we can correct the deformity. Let's see. Now, what I did was we did a good posterior medial release to correct the deformity and do a good correction by a standard HTO principle. I brought her just to neutral, maybe just a millimeter more than the central line, so about 53% in terms of medial lateral alignment. And this is how our X-ray looks at the time of fixation. What you can see is you have corrected the subluxation of the knee. You got her alignment back to normal. This is a supine X-ray on table, so you won't see the medial joint opening yet. It only happens when she starts weight bearing. This is the video of her osteotomy after fixation. The key thing here is opening is more anterior, less posterior. So I've changed the slope of her knee as well. So this will correct the PCL deficiency in her. You can see the amount of release I've done on the back here. I've used the same old incision, extended it slightly anteriorly. Now what this does is that you can correct the fixed posterior subluxation. The commonest cause of fixed posterior subluxation is a tight capsular contraction on the posteromedial side. There's also some on the posterolateral side, and sometimes you need to make a lateral incision to correct it as well. And this is how a correction is done. Now she did remarkably well. I called her yesterday night when I was doing this presentation, and that's the message I got on WhatsApp from her. So you can get brilliant fixation and brilliant results by doing osteotomy. Key thing is to plan your surgery properly. You have to assess what deformities you're dealing with to correct the alignment as such. That's a simple example of the versatility and the power of osteotomy is to correct deformities following tibial tattoo fracture. One more case, I won't take too much of time today. So this is slightly older, about 5 years back. 22-year-old male, fairly active patient, was on his bike, had an RTA, had a tibial plateau fracture, which was felt to be not that significant and was managed conservatively. He presents 2 years post-op with instability in the knee and inability to bait very comfortably. The X-ray shows a tibial plateau fracture with anterior depression. So as you can see here, there is about 6 mm depressed part of tibial plateau on the front, on the lateral part of the tibia, and this is how it was marked with on the CT. Now, this is a fairly unusual presentation. So he has proper instability in the knee joint. Now, this was a time when we had some access to patient-specific cutting guides and CTs for planning your correction, and we could think of a good planning for this deformity. So the plan was to do a lateral opening wedge tibial osteotomy along with an intra-articular vertical osteotomy to correct the deformity. So all sounds pretty weird, but you are essentially recreating your injury forces and reversing them to correct the deformity and putting some bone graft in. So these are patient-specific cutting guides that have been used, and that's the intra-articular osteotomy going vertically to correct the deformity. That's this cut, and there is a transverse cut here or an oblique cut here to correct the coronal plane deformity. And this is how it looks. It's pretty weird, I agree. So these are the two osteotomies that have been planned and performed in this patient to correct the deformity. And that's him about 6 months post-op. You can see it's almost healed. There was an inadvertent progression of the osteotomy from here to intra-articular. So the two osteotomies got coalesced, which is not expected. But we had to keep him non-weight bearing for 6 weeks for that. And that's the lateral view. You can see how funny the fixation looks. But that's him about 11 months post-op. Let me just see the video if it runs. Yeah, and that's him 11 months post-op. And you can see the amount of comfort he is when when he's able to do all these activities. So it's essentially you need to plan the deformity correction properly and do what is necessary to get the tibial plateau perfectly aligned. So it's not same as a normal arthritis patient. You need your CTs, your MRI, sometimes even the rotational CT profiles as well. You need to assess the personality of the deformity really properly. Remember all the 3 planes that you need to play with. Planning is the key. You are going to get some unconventional cutting involved when you're doing an osteotomy to correct deformities following tibial plateau fractures. There will be slow recovery and you may need concurrent or later ligament reconstruction. So I hope all of that made some sense. Thank you.
Thank you, Bhushan Sabnis. That was a very nice talk. Yes, Maji sir.
Yeah, there is one question. We can go ahead to this question or we'll wait for.
Can I ask, Dr. Prasad?
Yeah, please.
The last talk regarding, I'm Dr. Malikarjun here.
Yeah. We can't see you. Anyway, no problem. Go ahead, please.
The first case what we have shown STO.
Network
I believe that is a biplanar osteotomy. You must have used the Tomofix. And how did you correct the lateral subluxation in that case?
So one of the ways to correct lateral subluxation is to do significant soft tissue release posteriorly. So when you do a good amount of posterior or medial release, sometimes even you have to picrus the posterior oblique ligament as well. Then on table, you can physically push the knee and get it corrected, and that stays maintained as long as you push the knee in valgus. So this has been shown multiple times till now. I haven't published this, but there are about 6 cases where you can correct subluxation by releasing the soft tissues and holding that with your HTO correction in the valgus position.
In such situation, did you look for intra-articular any meniscal problem, meniscal stuck in that was not allowing
I haven't included that here. We did a scopy for her as well, and as expected, the medial side was completely mushy with almost a non-existent medial meniscus. But by pushing her in valgus, I think the medial load has gone down drastically, and she's now, I think, 18 months down the line, and we saw the message from her. So it's she's medial meniscus deficient, but because of her alignment now, I think she'll be all right.
You prefer to use Tomofix always?
So I have a wide choice of plates. I have a Tomofix plate. I use the peak power plate, or I use a new clip plate, depending on what kind of patient I'm dealing with. I think Tomofix is a good fixation plate for a normal sized adult. I use the plastic plate for women and short stature patients. But if I'm doing any complex procedures like concurrent ligament reconstructions along with my HTO, I have now turned to go for the smaller plate, the new clip plate, as active motion plate, as they're called. I'm sorry if it's all slightly foreign to some of the listeners, but generally, a lot of plating systems are available in HTOs. But you can even use a normal T plate as well if you want to.
Okay. Thank you. Thank you, sir.
So I had a question for for Dr. Jagdish. So one of the things is sometimes you will have situations where you have to do fracture fixation and also do ligament reconstruction. Some of them will be deficient with the ligaments. So how will you address that and how will you plan that?
Yeah, usually those comes in a, when there is an avulsion, usually avulsion fracture will happen. ACL avulsions can happen when there is an associated tibial plate fractures out there. So during when we are fixing this uh, plate fractures, usually we take a bite, the same openly, we take a bite around the attachment of the bone and fix it anteriorly. After, once if you put the screws, you see where your tunnel is supposed to come. During that time, you take out the screw and put it back and fix it, and later you just miss it and put a screw back to this position.
One question is there for Dr. Brahmraj. Can you take it from Dr. Devang Patel? Your preference for position, posterior medial plating, figure of 4 or prone position? Dr. Brahmraj.
I would be preferring prone position because in the prone position, I can have a better visualization of the fracture reduction and placement of the implant, and screw trajectory, I'll be more comfortable. I'm not used, because you want to reduce in figure of 4 position, you need to hyperextend the knee. So figure of 4, you cannot have a easy manipulation of the fragment. So I would prefer prone position.
The question extends to first lateral plating or posterior medial in bicolumnar plating.
It's not a fixed, hard and fixed rule. So if there is an associated depressed fragment and you have to strategically plan and elevate those fragments before your screws cross that area. So it all depends on the fracture anatomy and pattern.
Okay, thank you. One question for Dr. Ram Prasad. Can we fix anteromedial and posterior-medial fragment in one incision?
Yeah, we can do. But the anteromedial, probably medial you can easily do in one incision. Posterior medial and medial supporting plate can you put in the one incision to prone position as well. But anteromedial probably difficult. So in that case, you have to tunnel the anteromedial plate, the small incision anteromedially, and subsequently you can tunnel a plate, one screw above, 1 or 2 screws below, that can be done. But medial definitely can be the same plate, and posterior along with posterior medial.
Yeah, of course. One question to Dr. Sabnis. Patient-specific jig for osteotomy, where is it available, where it is made?
Dr. Bhushan Sabnis.
So you can answer that? Yeah. So you need to get them prepared with 3D printing technology where it's available. At present, we have some collaboration with IIT Powai who are ready to make patient-specific cutting jigs based on CT scan images. But you need to have a proper CT-based computerized planning software to plan your deformity correction. And you need to sit with someone from the institute to actually physically prepare the jigs for you. One of the companies, the new clip active motion from France, is actually able to do that for you. So you need to send a CT scan and whatever correction you want to them, and they will predict complicated deformities. It does make sense to correct all of them in one go rather than using a fixator.
Okay. And the question to Dr. Bhushan. Dr. Bhushan Sabnis, have you anytime, just, if you do not want to use any implant and you want to do HTO, have you done it with by just putting a bone grafting, bone plugs?
So I am a big fan of using the locking plate systems. The only time I don't use an implant is when I'm doing a significant slope change where I use the tibial tubercle itself as a biological plate. So you make a vertical longitudinal incision in the front, lift off the whole of the tibial tuberosity as a single biological plate, do your HTO, put a bone graft in and close it on top again like a lid and fix it with 5 or 6 screws. That usually works well. I when I was training long back, I like everyone else, I was trained to do an osteotomy without using any implants with plaster. Haven't done that in last 20 years.
Yeah, I think Dr. Rampasad sir, you have
Yeah,
got a lot of
yeah,
experience with, without implant.
yeah.
Tell me, sir.
We were doing high level osteotomies in quite some time. Where especially when a good quality bone is there, when you do intraligamentous osteotomy, especially when you do within the patellar tendon itself, the tension itself will hold the ligament. Good quality bone, especially when you do a tricortical chunk. I think when we can use it, without the graft won't slip out majority of the time. Intraoperatively we can see, we can put a plaster. We are using quite some time. But nowadays, to reduce the plaster time, we're putting a small semi-tubular plate to hold one screw above, one screw below, or even a K-wire, you can use it, cross K-wire, you can remove it also. And a good quality bone, as what is Jagdish says, I think we were quite some time, many years we are doing that, consistently good results. But the only problem comes in the fine tuning of what they are doing today, the amount of what the locking plates will give you the consistent result, no doubt about it. If they want to do a sloping osteotomy without graft, also they can do with a locking plate. I think they can avoid the graft as well. What do you say, Dr. Bhushan?
Uh, I think it needs special hands like yours to do such things. I think in my hands, a good plate fixation and feels very secure. I get my patients walking the next day of surgery. So no plaster, just a brace also is required. So I think more important than that is the accuracy of correction. I'm now aiming for let's say 8.5 or 8.10 or 9 millimeter correction. I can dial that 0.5 millimeters or 0.5 degree really well by using today's jigs. But for someone who's non-affording and of less demands with good quality bone, I think you can always do what you're saying. There's no question about that.
But Dr. Uday Kumar sir, how do you use it the same way you do it, or you have any other thing? Do you use regular plates?
No, no. Earlier, like
Steel
what Dr.
plates.
Raprasad said, we used to use your closed wedge osteotomy and plasters and all that. But now, of course, as Dr. Bhushan says, we have all shifted to your tomofix and locking plates because you can mobilize the patient very next day. You can start mobilizing the knee, touch weight, the bearing. So your implants have made life easier for the patient. Plus, as you said, you can correct it more. Like I was asking Dr. Bhushan, when does he use a bone graft? You said you use a bone graft if your opening wedge is more than 10 millimeters. Right?
Yeah. So it's just
So any reason for that?
so it's not imperative. The healing is very slow. If your correction is more than 10 to 12 millimeters in HTO, if you want to mobilize the patients, most of my patients, when the correction is more than 10 millimeters, it's just from experience that they are able to walk well. Their osteotomy feels more stable to them, and healing is pretty secure. Having said that, all of us have read papers where till about 20 millimeters of correction, no bone graft has been used with the tomofix system and without any issues as such. So evidence suggests otherwise, but Indian bones are not as strong as Western bones or Caucasian bones. And I would advise to keep the patients non-weight bearing if you're not using bone grafts and doing correction more than 12, 13 millimeters. But that's just my opinion.
And what is your experience? Because we've been using hydroxyapatite wedges compared to hydroxyapatite wedge with your autogenous graft. Any difference of opinion?
Um, it's there are two things here we're talking about. The ready-made wedges, whichever company you want to use the wedges of, they take time to dissolve, and quite a few times the cost increases quite significantly when you start using the wedges. So that's one point. And secondly, autograft or allograft tends to incorporate much faster. And I normally use allograft for most patients, but I'm more than happy using the autograft as well. So I'm slightly less inclined to use the wedges as far as possible.
Would you prefer using an ordinary T-plate? We are all used to Tomofix. We've seen some people using just an ordinary T-plate.
So if your bone quality is fantastic, if your osteotomy is really secure, you haven't caused a hinge fracture, and you are going to take it really slow in terms of rehabilitation and recovery of the patient, then a T-plate is equally good. So if people can use a T-plate, nothing against that. The advantage of systems like Tomofix is that they have a central thickened titanium area, which allows early weight bearing and supports the osteotomy. So we are all entering the fast world essentially. So it's not essential that you use this system specifically or something similar, but it allows you to mobilize faster. Chances of non-union are really less when you're using something like this, even if the patient inadvertently wears weight bear fully immediately.
Yeah, I have a question to Dr. Bhushan.
Yeah.
What's your experience on using external fixator for this multiplanar deformity with a gradual correction?
So long back, I was a big fan of Elizaraus in about 99 to 2002. Did quite a few Elizaraus for weird deformities. But again, if you look at the patient satisfaction, it's quite hectic for a patient's lifestyle to manage with an Excel fixator for 3 to 6 months on his or her leg. Well, I work with Anand Joshi, who's had a HTO in front of the Bombay Orthopedic Society with the Elizarov fixator. He wore it for about 6 months, and I have seen firsthand, I've heard from patients as well, that it's not the best of the things to have. That's number one. Number two, you're always worried about pin track infections. You're always worried about bacteria staying dormant inside those pin tracks for a long time. And number three is that I attended deformity course in Pune last year, and even he himself says that if an option is available, I would rather go for an internal fixation rather than external fixation as far as possible. This is good for the patients. And with the present planning systems and our improved knowledge of deformity correction, if we are able to achieve everything in one go, then with a good plate fixation, with current prophylaxis, antibiotic prophylaxis, our infection rate is less than 1%. I think if we can give that to the patient, they will be more happy. So nothing against external fixation. I only use it in my practice when the skin condition is not good. There are massive blisters around the leg, or there's fungal infection, or there is a skin flap which I can't deal with. Then I would go for external fixator. But generally speaking, my go-to is a plating system nowadays.
Dr. Jagdish?
Yes, sir.
What is your sequence of ligament repair? If there is a patient with ACL, PCL, MCL, and LCL, what do you do first? What do you do second? What do you do third?
Yeah, first what I do is first I will get all the tunnels, that is a PCL. First I'll go for the PCL, because when these type of multi-ligament injuries are present, invariably when you're putting a fluid, it can extravasate and can cause a compartment syndrome. So first I'll try to put the PCL. So then whatever, even if you just put a fluid, extravasation can happen over there, and you're not coming into a problem of a compartment syndrome. So first I'll put off the PCL tunnels, then go for an ACL tunnels, and then once if all the grafts have been put, I'm not going to fix it up right now. I'll just put it over there completely and go for a middle collateral ligament. I may use an anchor, or if I'm using a staple, what I'll do is I will put the PCL implant first, because since I do an all inside technique, I don't have any problem of putting screws. I have always both the sides. There is a button is there. Only thing is I have to cinch it and make it tight. So first I do the PCL and then go for an ACL and keep the knee in 30 degree and the neutral, and then go for a medial collateral ligament repaired with the either with an anchor or with the staples.
Yeah.
You
So
do the
Neeraj send,
TL.
hello.
Is the time over, sir?
Yeah, almost over.
Okay.
Dr. Neeraj just sent he has a meeting. Next
Okay,
meeting
okay.
is to start by 5:30. So closing
Right.
statement from Dr. Jagdish and Dr. From the president of KOA.
Is Dr.
Yes,
Malik-
Dr.
Dr.
Mallikarjun, sir.
Malikarjun?
Yeah.
He has to
Yes.
unmute himself.
Yes. Dr. Mallikarjun, sir,
Is he there?
20.
is there. Okay, anyhow, thank you very much. Is come. Yes, sir, Mallikarjun, sir.
Yeah, he's
No,
come.
before you tell thank, I should be thankful to all brilliant speaker.
Yes, sir.
And really KOA is honored. Okay.
Yeah.
Yeah, I expect in future also. Okay. Thank you, and all. Thanks to all speakers and participants.
Thank you. Thank you very much, sir.
Thank you
Thank you very much.
Thank you, sir.
Thank you.
Thank you. Thank you very much, sir. Ram Prasad, sir.
Thank you.
Bhushan,
Thank you.
Niranjan,
Thank you.
Nirjan, Brahmaraj. So, good day, sir.
Thank
Thank
you.
you. Thank you very much.
Thank you.
Thank you.